At this point, let us assess the venous and the arterial pulses. For the venous pulses, we take note the assessment of the neck veins of your patient, especially the JVP or the jugular venous pressure. This estimates the filling volume and the pressure on the right side of the heart, and usually if there would be an increase in the pressure, there could be an increase in the jugular vein pressure. So there is a presence of jugular vein distension found onto the anterior portion near lateral portion of the neck. The normal JVP is about 3 to 10 centimeter water, and an increase in the jugular vein pressure may be an indication of the presence of the right ventricular failure, tricuspid regurgitation or stenosis, pulmonary hypertension, cardiac tamponade, constrictive pericarditis, hypervolemia, or a superior vena cava obstruction. So it is measured, remember, when a patient is lying semi-Fowlers on the bed, about 15 degree. Okay, so we look or inspect onto the anterior portion of the neck and observe for any pulsation of the jugular vein. So we measure it from the angle of Louis. We take note that the angle of Louis is between the junction of the sternal notch and your flat bone of the chest, which is your sternum. So from the angle of Louis, it measures from the right atrium an automatic or a constant of 5 centimeter or 5 centimeter water. So from the angle of Louis, we measure up to how or up to when would be the jugular vein appears to be with. Okay, so we take note the top portion of the or the highest portion of the jugular vein, which is filled, and we measure it. So in this example, from the angle of Louis to the highest point of the jugular vein distension is 2 centimeters. So it adds 2 to the constant 5 centimeters, which makes it about 7 centimeter water as a jugular vein pressure. If it is 4, for example, from the angle of Louis like this one, from the angle of Louis to the highest point of the jugular vein, a resulted to 4, you add 4 to 5, which makes it 9 centimeter water. Okay, we now check the arterial pulses. So we do examine the peripheral pulses in a head-to-toe manner, which with side-to-side comparison. A hypokinetic pulse is when the pulse of the patient appeared or palpated to be weak and may indicate a narrow pulse pressure, and a hyperkinetic pulse is described to be a bounding pulse. There is what we call also an alternating of these two kinds of pulses. Alternating of a weak and a bounding pulse is termed to be your pulsus alterans. So, brewy, meanwhile, is a swishing sound auscultated that may develop in 50% of the narrowed arteries and usually associated with atherosclerotic diseases, such as can be seen or can be heard over the carotid and the aorta. So how do we determine the presence of bruit? We place the bell of the stethoscope over the skin of the carotid artery while the client holds his breath. So take note of the presence of a swooshing sound or a turbulence of the blood as it passed through the blood vessel. Upon inspection of the chest, we take note of the patient's precordium. Okay, when we say precordium, it is the chest of the patient. In this assessment, we utilize inspection, palpation, percussion, and auscultation. The client's position should be in a supine position with head of the bed slightly elevated. During inspection, we check for any presence of a visible vibration. Any cardiac motion of low amplitude and inward movement is easily detected. If there would be presence of uh, movement in the right second intercostal space, also, as well as in the pulmonic left second intercostal space and the tricuspid found onto the left fifth intercostal space area, may be an indication of abnormality. However, it is considered normal if there would be an apical impulse or a point of maximal impulse found onto the fifth intercostal space of the midclavicular line. So we take note of the different locations wherein we should auscultate the patient's heart. So we auscultate onto the second intercostal space, right side or right sternal border for the aortic valve. For the pulmonic, we auscultate onto the patient's left sternal border at the second intercostal space. The third left intercostal space near the sternal border, as well for the listening over the herbs point. And the mitral area, also considered as the point of maximal impulse, we auscultate at the fifth intercostal space, midclavicular line. For the tricuspid, also in between the third and the fifth intercostal spaces at the sternal border. Upon palpation, we detect presence of precordial motion and thrills. Okay, thrills would be the congruence of your bruit upon palpation. If bruit is heard during auscultation, thrills are the ones felt or palpated as a turbulence upon palpation. Check for the presence of heaves and lifts, which may describe pulsations associated with valvular diseases or pulmonary hypertension. A presence of thrills or the vibration associated with the turbulent blood flow may be caused by an abnormal heart valve function. For percussion, however, is very limited utilized or limitedly utilized assessment technique upon checking of the cardiovascular system, specifically the precordium. For the auscultation, we evaluate the rate, the rhythm, including the cardiac cycle and the valvular function. Valvular function may be heard over the points that I have mentioned earlier with the pulmonic, aortic, tricuspid, and the mitral. Diaphragm of the stethoscope should be utilized for the identification of high frequency sounds, usually the first and the second heart sounds, or your S1 and S2. And it should be repeated utilizing the bell. Since the bell is useful for listening of low frequency gallops and murmurs, it may help in the identification of cardiac problems. The normal heart sounds are your S1 and S2. S1 is made by the closure of the AV valves, which is usually softer and longer. It is low pitched and it is best heard over the left sternal border or the apex of the heart. It marks the beginning of a ventricular systole and accentuated and intensified in conditions such as exercise, hyperthyroidism, and mitral stenosis. Decrease in intensity usually in those cases with mitral regurgitation and heart failure. S2, meanwhile, is caused by the closing of the semilunar valves, shorter usually, and is high pitched, heard best over the base of the heart and at the end of the ventricular systole. S3 and S4 are considered to be abnormal heart sounds. So they are diastolic filling sounds when blood enters a non-compliant chamber during rapid ventricular filling. S3 or atrial gallop is a rapid passive filling phase of the ventricular diastole when blood flows from the atrium to the non-compliant ventricles. Presence of vibration of valves and supporting structures may be heard. However, it may be considered normal to those of patients who are children or young up to 30 years of age. If it is more than 35 years old, it may be considered already as an abnormal finding. Usually, may indicate a decreased ventricular compliance or an early sign of heart failure or a ventricular septal defect. S4, meanwhile, is your ventricular gallop. When blood enters the ventricle during the active filling at the end of the ventricular diastole and may be seen in patients with hypertension, anemia, ventricular hypertrophy, myocardial infarction, aortic or pulmonic stenosis, and pulmonary emboli. It is also heard in those of patients who are advancing in age because of the stiffened ventricles.